So thank you, everybody, for coming along to Daria, the Drug and Alcohol Research and Innovation Active Learning. Today, we are lucky enough to have David St. Quentin coming to us from the Illawarra Drug and Alcohol Service team. He's a clinical psychologist who works specifically in the youth drug and alcohol team down south. And a bit about David, he, as I say, is a clinical psychologist who didn't realise how much he enjoyed working in drug and alcohol. He started with the Youth Drug and Alcohol Service of Illawarra Drug and Alcohol about 18 years ago. He's worked in the clinic settings and in outreach to vulnerable young people who are homeless, underhoused, those in and out of home care, and recognise the importance of flexibility and approach to meet people where they are in their journeys and build trust with people who have often had their trust abused in ways that have profoundly damaged them. He believes that the drug and alcohol setting provides a valuable opportunity to support people with their mental health and trauma issues that other more specialised services sometimes don't have, which I completely agree with. His desk is a mess. He's easily distracted. I know the feeling. And he does not find joining committee meetings, and so has studiously avoided any success or achievement that might progress his career away from his clients. And certainly it is a challenging dichotomy that you raise there, David. And as a side note, at his peak, his 10-pin bowling average was 167, although his performance has suffered due to becoming old. I'm sure you could still spin a 200 if you wanted to, David, at some stage.
On a good night, perhaps.
David is going to be talking to us today about motivational interviewing and trauma in the alcohol and drug space. Take it away, please, David.
Great. Thanks for having us along here. Just the only minor correction is that today I'll be focusing mainly on the PTSD and assessment and treatment of trauma in drug and alcohol settings. I may also be invited along to do a motivational interviewing one down the track, but I suppose that will depend on how badly I stuff this up. I also know I was told that there might be some people coming along from southern New South Wales. If that's the case, some of you may have even seen this presentation before. So if that's you, feel free to, I suppose, stay logged in so you get the professional development hours, but perhaps, yeah, if you've seen it before, make yourself a cup of tea and have something nice for afternoon tea, and maybe dip in and out as you feel to. So today we'll be talking about PTSD and in the drug and alcohol setting. It is a little bit broader than that, though, because I think in the course of this, we'll touch on various different manifestations of trauma and how they can affect our treatment, but also how we can be quite effective in treating them in ways that we probably don't realise that already involve a lot of the skills that we bring to our client interactions anyway. So the bits that I'll be talking about, firstly, assessment and diagnosis, and some of the issues of importance around that, and also treatment and how we can actually work with our clients who have experienced trauma in ways that are more helpful and more effective and that don't contribute to re-traumatizing them as well. Finally, I do have a little bit of an illustrative case study of Ken, which hopefully will bring some of those things that we discuss together so that you can actually get an idea of what I'm talking about in a way that's a bit closer to how we actually use this information when we're working. So there's a number of different ways that trauma can be involved in the presentations of our clients. Obviously, the first one is when people have a diagnosable post-traumatic stress disorder. That's the obvious one. Someone arrives, they have a diagnosis of PTSD, or they have all of the symptoms, they tick all of the right boxes to meet that criteria, and they also have a drug and alcohol problem. But also, and probably more problematically, we also have a lot of people who present with, complex post-traumatic stress presentations that share a lot of similarities with borderline personality presentations. And I'm sure anybody who's worked in the drug and alcohol field for any length of time, we'll be, really clear on the fact that a great many of our clients have various personality issues. A lot of those personality issues, in some way, when we drill down into it, come back to traumas that they've experienced. There's also, and this is a slightly newer area as far as research, there's the notion of adverse childhood events. I'll get into this a bit more, but they're those sort of childhood factors that don't perhaps meet the criteria for being traumas in and of themselves, but go together to make for a less than ideal environment that our clients grew up in, and that have, long-standing consequences that the research is starting to make clear. And sometimes we have people who arrive with a mix of all three of those. They might have a diagnosable PTSD to a specific incident, as well as a long-standing pattern of complex PTSD symptoms and a thoroughly, abysmal childhood as far as the experiences that they've been through. Each of those presentations involve different challenges, but they do have some common factors. So I'll go into each of them a little bit. So post-traumatic stress disorder, that's of course an actual diagnosis. What makes it tricky is that it's most easily and clearly seen when it occurs in response to an identifiable event. So somebody has a car accident, and at that point, their trauma response to that event leads to symptoms that change things from there on in. Or they have experienced an assault, or a natural disaster. Why that can be problematic with our clients is that, as I'm sure you know, most of our clients have a number of different traumatic events that they've experienced in their life. To actually specify which one of those is the traumatic event of most importance to their PTSD symptoms is difficult, if not impossible. Sometimes they can't be separated. It's not even a series of discrete traumatic events, but an ongoing trauma that might have been in their life for years. So the diagnosis requires that history of the traumatic event, and the way it's defined in the DSM is an actual or perceived threat of serious injury or death, or threat to bodily integrity. So it has to be something where the person feared that they were going to die, or that their body was violated in serious ways. So that covers things obviously like accidents, injuries, assaults, and sexual assaults as well. That's been made clear with the threat to bodily integrity criteria, so that someone doesn't have to actually believe that they're going to die in that circumstance, but it is definitely still a threat to their bodily integrity. DSM-5 also includes indirect witnessing of the traumatic event. So it can be an event that they didn't experience directly, but they witnessed. They might have learnt about the trauma occurring to a loved one or close friend, and it might involve indirect exposure to the details. This is important for our purposes too, because that includes vicarious trauma, the sorts of trauma that we're exposed to when we're dealing with these people. That these people bring to counselling and the clinic setting some really serious traumas that have affected them, and then they share those traumas with us. We become indirect witnesses to those traumas, and that can have an effect on us. So we need to be conscious of our own well-being. We're not superhuman. We're not invulnerable to taking some of this stuff on board, to it having actually damage us. And that's why it's important for us to be taking care of ourselves. Here are the diagnostic criteria for PTSD in the new DSM-5. This is the point where typically a presenter will go through each of those individually, and it will bore the pants off everybody listening, and everyone will instantly forget as soon as they log off from the presentation. So I won't do that because it's a waste of time. It's online. You can access the DSM criteria online anytime you want. You can all read, I'm sure. What I think is more useful, though, is to think about it in terms the ways that we can remember when we're in the room talking to people. And I think it's useful to think of it in terms of the pirate words. Those R, which is R, A, and A. R. That involves re-experiencing. If somebody is experiencing each of these, then there's a better than almost certain chance that they actually have PTSD. So the first is the re-experiencing symptoms, things like flashbacks and intrusive memories. The next are the arousal symptoms, so the hyperarousal, the hypervigilance, the chronic stress tension. People will talk about holding it in their shoulders or their jaws or in their hands, and the emotional reactivity. All those things indicate that their nervous system is spending most of the time on a knife edge, ready to pounce. The third one, the second A, avoidance. If a person's avoiding triggers, and they can be people, places, and things that remind them of the trauma or the traumatic events, and also avoiding thoughts or feelings associated with the traumatic event. And that's where it can be really important in doing a functional assessment of someone's drug and alcohol use, that if part of the reason that they're drinking or using or smoking pot is to avoid the thoughts and feelings that come up about their traumatic experiences, then that might be a good indication that there's a PTSD process going on there. I like this one because it's easy to remember. I can be in a conversation with a client, bad stuff can be coming up, and I can still kind of ask myself to think like a pirate for a bit. And are the criteria that are useful to investigate. Next, we've got the complex PTSD. This was first sort of described by Judith Herman, and her book Trauma and Recovery is brilliant for anyone who hasn't read it. It's quite readable. It is available as a free PDF online. I haven't chosen to share it because I'm sure that would be illegal in terms of some copyright laws. But suffice to say, if you Google Judith Herman Trauma and Recovery free PDF, you'll be able to find it pretty easily. So she talks about complex PTSD as stemming from repeated and chronic and inescapable trauma, especially in childhood. So this gets to that notion of trauma for those people who don't have the one specific traumatic event, but they might have lived most of their childhood in a traumatic environment where mum and dad might have been using drugs and alcohol themselves. There might have been domestic violence in the house that was ongoing. They might have been witness to it or even victim to that. There might also have been childhood sexual assaults and sometimes, prolonged experiences of that. Homelessness, all of those different things that can disrupt people's emotional development go together to lead to chronic complex PTSD in a lot of people. So it has similar diagnostic criteria as borderline personality disorder. And in fact, if you hold them up next to each other, they pretty much overlap almost one-to-one. It's not a recognised diagnosis in DSM, but it is in the ICD, in the International Classification of Diseases. So given that DSM is used mainly in North America and Australia, and the ICD is used more commonly in Europe, it is an actual legitimate accepted diagnosis in Europe, but not so much in North America. And depending on the study, around 30 to 90% of people with borderline personality have a history of childhood trauma. So it actually helps to make some of those borderline personality symptoms make some sense. These are skills, abilities, tendencies, and habits that people have learned to cope with inescapable and prolonged traumas through childhood. And they kept them alive then, but they brought those with them into adulthood and they're not working anymore. And so this is why it's complex. It's relevant for our clients because this is often how they present by the time they come to us. This is adapted from Judith Herman's work. I won't go into all of it, But basically what it does is that this is a model, and you'll have these slides after this. So if you want to look back on it, it'll be there. Goes into the different symptoms that are involved in complex post-traumatic stress disorder. And around the outside are the treatment approaches that work to target each of those. I put this in only because I think it's really interesting that if you go around just the outside, things like distress regulation, modelling appropriate attachment, re-establishment of values and appropriate expectations, psychological awareness of the link between symptoms and situations, it becomes clear that most of what's involved in that is stuff that in one form or another in drug and alcohol we're already doing. And I think that's reassuring, so that when we have, when we're talking about things like trauma, drug and alcohol, we're not talking about something that's completely alien or foreign. These are things that we already do, and we actually do well. The last category was adverse childhood events, so ACEs. And there is a relatively new, but it's a growing body of evidence supporting the relationship between adverse childhood events and subsequent pathology. So ACEs are not necessarily traumatic in and of themselves. They can be, but even when they're not individually, they have a cumulative effect on stress levels. And the relationship is quite linear. The more ACEs a person has in their childhood, the more likely they are to have mental health issues in the future, and the more severe those mental health issues are likely to be. These can include things that are traumatic, and like frank abuse, physical, sexual, and emotional. Also things like neglect. A lot of the individual events involved in neglect are not in and of themselves traumatic, but they're things that over the pattern of it become quite important. And also some of the more sort of general household dysfunction factors that our clients encounter, things like parental mental illness, exposure to domestic violence, exposure to substance use by other people in the family. A lot of my clients, and I'm sure that yours are similar, might be sort of third or fourth generation of people growing up with histories of drug and alcohol abuse in the families. We see them at 20, but their parents were smoking pot at home the whole time through their childhood. Their grandparents smoked pot all the time through their parents' childhood, and so on. And another one is incarcerations and sort of traumatic separations from families. So included in that list of adverse childhood events are things like parents going to jail, being removed by fax, and all of the other, horrible experiences that our clients experience. This is useful even to pause occasionally and think about what percentage of your clients had ideal childhoods. And there might be one or two that you can remember, but by and large, most of them didn't. A lot of them didn't even have what we would describe as good enough childhoods. So even if there's not a frank trauma experience there, a lot of the same things might be at play under the surface. Because there are some biological similarities that all three of these involve. They all involve dysregulation of the hypothalamic pituitary adrenal axis, or the HPA axis. So that's the pathway in our brain that's involved in regulating our responses to stress. So trauma impairs the HPA axis ability to regulate its own response to stress. It's been described as basically like having your alarm response always on. That's how trauma works. We know this. I'm not telling you anything here you don't know, but traumas, when they're big enough, they basically hit that alarm switch so hard that the alarm stays on. And similarly, the ACEs result in sort of permanent calibration of that HPA axis so that it's more reactive in response to stress and less able to regulate itself. It reacts quicker, stronger, and it settles slower. And sometimes it doesn't settle at all. That makes sense if you think about a child growing up in, a very erratic and unpredictable and dangerous environment, they actually do need to be aware of danger. They do need to stay on alert when there's danger, because the danger might not go away. They might even need to be alert all the time. And these are the brains that they're bringing into adulthood and that we encounter in the room when we're trying to help them deal with their drug and alcohol use. So how do we assess? How do we assess for traumatic events and for PTSD? It can be really challenging, because the number one thing I think that gets in the way of it is that these traumas most of the time represent really extreme abuses of trust. So these people that we're dealing with who've been through this, them being distrustful is actually quite wise. They have been through events where their trust has been abused, and so now they're not going to hand that trust out easily. So it helps to keep them safe, but it makes our lives a little bit more difficult when it comes to, establishing that trust in the room and doing an assessment. People with traumatic backgrounds often have complicated histories as well. Sometimes we might have spoken with them for 4 or 5 sessions and still be quite clear that we haven't even gotten half of the story yet. There's so much that has gone on. There's also often a disconnect between client stories and the emotions attached to them. So that can make it really difficult to really understand what's important for people. They might present to you things that sound on the face of them horrible, but there's no, real distress associated with them. That's been dissociated off. And that makes it hard as a clinician to work out, is this something that actually is important? Or are they just describing to me something that happened but didn't have much of an effect on them? And that can take a while to piece out. And trauma simultaneously calls attention to itself and distracts from itself. So it will often manifest in lots of drama, lots of high levels of distress, but the distress is presenting in a way that it actually distracts from the trauma underlying it and focuses on often the less important aspects of the situation that have triggered them. So it's about a fight with a friend when it's actually not about the fight with a friend. It's that this is the same underlying trauma response that's been happening all the time. So that's why I've used the grumpy cat here, because I think that's a good way to think about it. That in the same way that cats will demand your attention and reject you when you go to give it to them, and then get mad at you for listening to them rejecting you, this is how trauma plays out. Add to that as well, that obviously in people with histories of trauma, we have to be assessing safety as well. We know that people with a history of trauma have an increased risk for self-harm, increased risk for suicide, increased risk for reckless behaviour and misadventure. So that needs to be overlaid on top of it. And sometimes that might be, where we spend a lot of time. It's just in establishing that safety. But we'll come to that a bit more later too. As far as assessment tools, obviously there's no blood test or anything, or X-ray that can test for PTSD. There are some psychometrics that can be used. They're mainly inventories and structured clinical interviews. They're probably not all that useful for us. They're relevant perhaps in research settings and forensic settings, or anywhere where somebody's trying to seek compensation, but they don't really help guide treatment. They're not what people are here for, and they can be very time consuming and really intrusive. The last time I had to do a skid with a client to assess PTSD, you open up the PTSD module, the very first question basically is, tell me about one of the traumatic events in your life in some detail. And that, as you can imagine, for a lot of our clients is just cruel to come in to somebody who they might not have seen or might not know very well, might not yet trust, and to be asked to lead with that. It can be counterproductive and actually harm engagement in the long term. So what's that leave us with? Basically the things that we bring into the room if we don't bring anything into the room. It's our eyes and ears. We can assess trauma through conversation. We can assess it by noticing what's there, looking for and asking questions around the RRR, noticing what's not there as well. Are there important bits missing to this story? I went away on, camp with this coach, and when I came back, I, ended up in hospital 3 weeks later. There's something missing there. If there's any emotional incongruence, like the example I used before of when people might talk about an event that is objectively really horrendous, but there's no emotion attached to it. And so just through the compassionate use of basic counselling skills, basic in inverted commas, because we know that with these people, basic counselling skills are not basic. They're actually really hard work. They challenge us to not get carried away with our own stuff, to not, get frantic about establishing trust in ways that push them away. It takes patience, because we might take some time to build that trust. Our first task in the room is to create safety, psychological safety, so that they feel some confidence that they can disclose this stuff to us, they can talk about it without it being harmful to themselves, without it destroying us, and without us using it as ammunition against them. The client needs to be in charge of the pace of disclosure, so there's no risk of re-traumatisation. And we need to take a careful focus on the functional role of drug and alcohol use in the trauma avoidance. So to see how is this person using their drug and alcohol stuff to avoid the distressing things that they've experienced. So the initial focus is likely to be on here and now consequences of traumas. In dealing with trauma with drug and alcohol clients, there may be times when we actually don't talk too much about the trauma, but what we talk about is how it's affecting them here and now. What we can do, there is a very unproductive argument that I would encourage you not to get involved in, because it's a waste of your time and energy, which is that sort of chicken and egg argument that comes up when we're dealing with other services often, about what is the primary problem. Is this person's drug and alcohol use primary and they have to treat that before they can deal with the trauma? Or is this trauma primary and that's what's driving the drug and alcohol use? They're pointless questions. They don't actually help our client. And most of the time, the trauma symptoms and any other mental health symptoms and the drug and alcohol symptoms, as we know, are all part of the same problem. They're part of the same constellation of things that aren't working in this person's life, and they're all interrelated. In any case, current research supports the idea of treating both of them together, and also that treatment is best delivered by one primary clinician, at least one primary clinician at a time, not divided across teams. So as appealing as the idea is, that notion of, oh, well, I'll deal with the drug and alcohol stuff and the trauma service can deal with the trauma stuff, doesn't work as well as looking at both of them together. Yes, and this is what I was saying before, that it's new territory for drug and alcohol in the sense of yes, but actually no. We don't think of ourselves as providing trauma counselling, but we are. We tend not to spend a lot of time unpacking traumas in the way that a specialised trauma service might, but we do tend to work on those strategies that help in the here and now with the effects of those traumas that are ongoing. So it's not beyond our scope, it's not beyond our ability, because we're already doing most of it anyway. So when it comes up and we have that initial reaction, which a lot of us do, of like, oh shit, this is well beyond my abilities and I'm out of my depth, I'd encourage you to kind of step back from that a little bit and go, actually, maybe I can do this. Maybe I already am. Certainly seek supervision around this stuff, but don't out of hand dismiss it as something that's beyond what you can do. We'll look into some of the sort of treatment stuff in a second, but I'll just say right off the bat, we're not going to be looking at EMDR, because it's not that EMDR is necessarily magic, because it is growing in its research base, but it does require specialised training. I don't necessarily agree with the reasons why they say it works, but the research seems to indicate that it does work for whatever reason. But yeah, if you have a client that's interested in it, by all means refer. Wasn't sure which picture to use for that. I do like the Doctor Strange one because it looks like he actually is doing EMDR. But yeah, won't be going into that today. So as far as treatment options for trauma, there's a variety of approaches that have traditionally been used. So narrative and supportive therapies have been popular. Unfortunately, both of those have not done a great job of doing much research on themselves. So even though there's a very good chance to believe that both of them work, we can't look at the literature and point to the studies that confirm that for us. The option with the most empirical support is CBT. It's worth looking into because the research on it is really clear that if someone arrives with trauma and drug and alcohol use, and if we treat the drug and alcohol use without treating the trauma is going to stay there and people are likely to relapse on the drug and alcohol use. If we treat the trauma and not the drug and alcohol use, the drug and alcohol use is likely to decrease anyway as the trauma decreases. So having some understanding of a model, at least, for how we can work with that trauma stuff is important. So CBT involves, when it comes to trauma, involves psychoeducation, some cognitive reinterpretation of the trauma, and developing skills to allow for some prolonged exposure. We know that exposure is the most effective treatment for extinguishing anxiety. CBT, however, in the past and at times in the present, has been pretty brutal and clumsy with trauma. There's treatment models that strictly ask for people to engage in repeated exposure to the details of the trauma. That can involve things such as them recording themselves describing their trauma over and over again and listening back to it for 40 minutes at a time to extinguish the anxiety from that. I don't propose that you should do that with your clients. That seems to me to be cruel. It seems to me to have a very real risk of re-traumatizing people. And it also seems to me that in doing that, we're taking the horror out of something that is really horrific. That what we're extinguishing there is not anxiety, but perhaps what we're doing is encouraging more dissociative splitting of the trauma from the actual, emotional reaction to it, which I have moral objections to. I don't think we gain anything by taking the horror out of things that are horrific, but we can gain something if we help people to be able to cope with the things that come from those horrific experiences. But thankfully, we don't have to buy the cow. We can use bits of it without having to use all of it. There's one that's been particularly well studied, which is COPE, and it is a model for the simultaneous treatment of drug and alcohol and PTSD. It requires a really careful functional assessment, and that's okay because this is something that we know that as drug and alcohol workers we're very good at. It's very unusual for us to talk to a client in an initial assessment and have a supervisor ask us, why is this person drinking or using? And for us to go, I don't know. That we are usually able to have a pretty good hypothesis, which is often correct, as to why they're using. They're using because they're dealing with their anxiety, or because they're bored, or because they need to stay awake to drive their truck, or because, we're able to assess the function of it. So the COPE program focuses on preparing for people for exposure to the things that they're pathologically avoiding. So where I think this can be useful is to think about what they're avoiding is not just the trauma or the trauma memories. So when we're doing exposure for people, it's not necessarily on just going over and over and over and over again on the trauma, but they're also avoiding a lot of other things. They're avoiding negative feelings. They're avoiding people or situations. they're using drug and alcohol use to avoid some of those feelings. So the exposure that we might be doing with them might be more along the lines of looking at the other things that they're avoiding and helping them to find ways to sit with that sitting with and exposing themselves to negative feelings, or sitting with and exposing themselves to some of those situations where they might normally have resorted to drug and alcohol use, but not engaging in that same avoiding behavior. And that can start with imaginal exposure to those things in the room, and it can also involve imaginal exposure to the trauma itself, but it doesn't have to. Hopefully that makes sense. If not, throw the questions in the chat thing down the bottom, and at the end I'll try and clarify it if I need to. So the preparation involves psychoeducation and skill building so that people are ready for it. The ingredients of the treatment. Psychoeducation just around what the normal effects of trauma are. Talking about the hypothalamic pituitary axis and how that manifests in the RRR symptoms, and a rationale for exposure to what's being avoided, so they understand. Share this with the clients. It doesn't need to be secret knowledge that we have that we try and kind of just employ. We can actually do this together with our clients if we talk through with them. And in fact, that's a safer way to do it. This preparing is actually, for some people, that might even be enough for them. I can recall, a situation with a client where we'd been doing some psychoeducation on trauma. We'd spoken about how it affects the brain, and it was making a bit more sense to her. And as a quite off-handed response, when we were talking about preparing for exposure, I said, this is something that we'll do together because, we don't want to repeat traumas. And that's what trauma is that your trauma in particular was one where the control of your body was taken away from you, and I don't want to repeat that. This young woman at that point just kind of stopped, and I realized that something had happened. I didn't know exactly what. I was a bit nervous, thinking I'll put my foot in it somehow. But when I asked her about it, that alone just sort of that rationale that this was about her getting control back over a situation when control had been taken away was a way that she'd never thought of trauma before. It's a very normal way for us to think of trauma, but this was brand new to her. And at that, she actually asked pause. We moved on to other things. She said, let's not go there and do the exposure just at the moment, because I need time to process all of that around notions of control. And she got a lot out of just the preparation without ever having to do it. It also involves skill building. So being able to use things like SUDs, or the subjective units of distress. Most people are familiar with them, where 0 is I'm, cool as a cucumber. I couldn't be calmer if I tried. 10 is I am about ready to explode. I'm that freaked out and panicky. And being able to rate themselves as they're talking or as they're engaging in an activity. What's my SUDs at now? Building skills for delaying drug and alcohol use. If they're going to be in situations that they've been avoiding, then they might need a little bit of work ahead of time so that they've got some skills so that they can do that without using in those situations. Skills for self-soothing, reassuring themselves, practical strategies for self-assertion. And you'll notice that you recognize all of them because they're all basic relapse prevention skills. They're the things that we do with people anyway. The prolonged exposure is to whatever they're pathologically avoiding. So to start that, you need to have a clear and collaboratively designed exposure hierarchy that can include what feelings, what thoughts, what situations they're avoiding, and planning for some prolonged exposure to those situations, or those feelings, or those thoughts, that's long enough to allow for anxiety to decrease. When we're in a situation, even if it's an anxiety-producing situation, over time our body gets used to it and our anxiety comes down. If we try and do exposure and we finish it before the anxiety has come down, it'll actually reinforce the anxiety and make it worse. So what we want to do is plan for exposure that's long enough that the person can start to feel comfortable, or more comfortable at least in that situation, and finish it there. And the more they do that, each time it kind of gets lower. It also involves reflecting in counselling to decatastrophize experiencing those thoughts. Yes, I went into the pub and I was really tempted to drink. And to recognise that having that thought in itself is not a bad thing. You know, I went to work and I hadn't had my drink before I went there. And I really felt tempted to, and you're going, well, that's great. The aim here is not to remove the temptation, is not to remove all of the horrible feelings, but to get a bit, feel a bit stronger in handling those. So it doesn't necessarily involve unpacking the trauma or repeated exposure to the details of the trauma, which is good, I think. But what it does involve is a lot of reflection on those experiences of anxiety and those experiences of avoidance in the session. So helping them to counter that avoidance, to actually do some of the things that they've been avoiding, and then helping them to see that they've done it and reflect on that to build mastery. There's some caveats, of course. Care needs to be involved. Sometimes people just aren't ready or prepared. If they have just left detox and this is their first experience of sobriety in 15 years, now might not be the time to do this. Now might be the time to focus on strengthening some of those basic skills more. Going too quickly can be re-traumatizing and harmful. It has to be at the client's pace. SUDS is a really good tool to use as guidance for when the right time is. You can start with imaginal exposure and frame the exposure basically in terms of experiments. What happens if? And then they can see. It takes some of the pressure off it. And so for a lot of our clients, it's going to just involve doing the things they normally do with drugs and alcohol without drugs and alcohol. And the big one is, for some people, we mightn't be able to do prolonged exposure at all. Some people are not ready to take those steps. Safety has to be the first priority. Some people might be so emotionally dysregulated or impulsive that we reach that decision, this is too risky. If I try and do this, this person may kill themselves. And that's an okay call to make. That's part of our professional judgment. Also, the evidence suggests that it might not be very useful for people who have cognitive impairments. And the research indicates that a lot of our clients do. So if you're doing this, have a think about whether cognitively they're going to be able to take advantage of it, and be mindful of it too, so that if it turns out that it's not working, if they have impairments that are getting in the way, you can stop it. Just because you start something doesn't mean you have to continue with it. We can change our treatment plan if it's not working. And also for some people, this current contact might be just a part of that initial process of building trust and engagement, and that the actual dealing with the trauma might happen down the line, maybe in a few years, maybe with another clinician. This is just part of them starting to feel safe in talking about it. Some of our clients, this is chronic, long-term, relapsing and remitting conditions that, it makes sense that sometimes they will arrive and they're not going to be in a position to deal with all of it right now. What I will say though too is, even though I've said that it doesn't necessarily involve going into the client's trauma in great detail, sometimes our clients do want to talk about their trauma. And we can find ourselves, I know I have times in the past, going, oh shit, this is too much. We don't want to open this up. And we put a lot of effort into shutting them back down again. Let's not go there. And that can feel really quite invalidating. So in those instances where clients do want to talk about their trauma, as long as it's not too traumatizing for yourself, I would encourage you to actually just to go with that a little bit. But don't discuss just the trauma, extend it. And by extend it, I don't just mean draw it out and get more detail or anything like that, but extend it to before and after. As they're talking about it, it's okay even to stop them and go, hang on, so that I can understand this. What was happening before this? What did you do before this? And before that? And then after they have talked about, the event itself, what happened after that? What did you do then? How did you look after yourself in the aftermath of that event? What that can do is helps to put the trauma in context of the events around it. So they might get to see that, oh shit, yeah, this was something that I did everything I could to prevent, but that it wasn't in my power at that time to prevent it. When I look at everything that happened before it, I did all the right things. And this happened. And afterwards, I actually did some things that really helped me. And that way it puts them as a bit more of an active participant in it, an active participant in surviving it, not in creating it or making it happen, because that's not the case. But to be able to kind of dispel some of those things as well. I can remember a client just recently who he was abused as a child, and one of his great painful aspects of that is that his younger brother was also, and he is full of shame that he didn't stop his brother from being abused, and that seemed quite rational to him. I should have stopped my brother from being abused. That was my job. And it's not until you actually go in what happened before that and look at the context. At the time that this was happening, he was 8 and his brother was 6. The person abusing them was an adult. And that helps to start some of those conversations around what could an adult have done? Or what could an 8-year-old have done in that situation to stop this adult? It wasn't in your power to do. You didn't fail to do something that you should have. And what happened afterwards? How did you look after your brother then? Oh, and it starts to see that instead of this survivor guilt that I didn't do what I should, actually I was supporting in the best possible way that I could. Putting it in context of those events can be really helpful. Putting it in context of the time of life. If the person was a child, of course, they weren't able to do everything to resist it that they'd be able to do now. They were doing it with an 8-year-old brain, an 8-year-old body. And extending it this way allows that conversation to happen in a way that the stress can come down. You can finish it at a point when you're talking about some of those more reassuring things. And that gives the person an experience of, I talked about this and it was okay. I survived it. The thoughts and feelings that this brought up didn't destroy me in the way that I thought that they would. And in fact, I left that session feeling okay. And that's an important experience to leave with. So to tie it all together, I'm going to talk a little bit about Ken. This is Funky Malibu Ken. He's one of my daughter's Ken dolls, and he has the coolest pants. So that's why I picked him. He's a 24-year-old man. He's referred by PMP in the context of a pre-sentence report. At the moment, he's drinking most days. He's finding it really hard to stop. When we're talking to him, he says he does want to stop and he thinks counselling would be helpful. So he's certainly at least in that contemplative stage of change. He kind of wants to, but he steps back from that sometimes into pre-contemplation as well, because during the first session, he's very standoffish and guarded. He'll acknowledge that he experienced abuse as a child by his father, but he explicitly and clearly says he doesn't want to go into details about that. He started regular drinking around 14 years of age. He'd often drink before school, no one noticed. Now he's drinking before work. He's been having trouble keeping work, as he'll end up in arguments with bosses because he's either hungover or drunk while he's there. His drinking even increased again recently after an unprovoked assault. while he was out in town. The police became involved and he ended up being charged as well. That's how he came to be involved with probation parole. Since that assault, he's been having frequent intrusive memories of his father's abusive behaviour, especially when dealing with the police and other authority figures. Describe some flashbacks. There's the re-experiencing. He's increasingly suspicious and untrusting of people. He's very hypervigilant. That's an A. The arousal. He's finding it hard to relax. A again. Has been attending a course, but is missing lots of classes because he's finding it hard to deal with his teachers. He's just not turning up. So he's avoiding. That's another A. And he can only attend if he has a few drinks first. He's going to be cut off Centrelink soon because he's not turning up to his course and appointments. But he's finding that the drinking helps dull the awareness of the flashbacks and gives a break from his constant anxiety. So that drinking is another avoidance strategy because he's dulling the emotional experience. What Ken needs, his treatment plan is going to have to involve some physical safety stuff. Is he still at actual risk? Is Dad still around? Because it feels Ken's 24. His dad's probably only in his 40s and potentially still dangerous. Does he still live with him? Is the person who attacked him in town still around? Is he being actively targeted by police? That kind of happens. Also involves emotional safety. That's another need that he'll have here. He'll need some time to develop trust in the counselling relationship. He's not finding it easy to trust authority figures at the moment because of his experience with his dad. And how is he sort of positioning you in this therapeutic relationship? Are you another authority figure who is going to have trouble trusting? Listening and being there and demonstrating that you're actually not going to replicate those same patterns as other authority figures is going to be really important, and taking time to do that. He'll need some psychoeducation to give him a framework. What is trauma? What does it do? Reassurance that he's normal. His situation hasn't been normal. It wasn't his fault, but he's been treated really poorly, more poorly than he should have been. And the reactions and responses that he's having now are a normal response to that. These are things that he might not know. We know this. We assume it's common knowledge, but he might not. We'll need to do a functional assessment. How's the substance use tied into the avoidance? And what is he avoiding? The situations. He's not going to his TAFE course. He's avoiding the feelings by drinking and dulling that. Sometimes too, and I think this is one that gets missed a lot, asking that question of, is the avoidance wise? Because some of the avoidance is wise. There might be times where he's going, and I'm avoiding my dad. And you go, well, okay, good. That's dangerous to go and see your dad. So yeah, that's a good form of avoidance. I avoid putting my hand on the hot plate of the stove when it's still red. That's avoidance, but it's a very healthy avoidance because nothing's going to be achieved by exposing myself to that pain. I'm not going to become better by injuring myself in ways that don't aid my recovery. You'll need to build some skills for affect tolerance. These might involve relaxation and self-reassurance. He's going to need to be planning for gradual reintroduction of the things that he's avoiding, which is basically constructing a bit of an exposure hierarchy. What am I avoiding? Well, maybe right near the bottom is I need to get to TAFE. Maybe further down the hierarchy is I need to get to TAFE without having drunk beforehand. And pacing it out once he has those skills to start being able to get back into those things that he's avoiding. And he'll need continued practice. That's how extinguishing of that happens. He'll need to build confidence in his own coping. And that's where our role can be really important too, reflecting on these experiences and actually pointing out when they go, oh, but I didn't do it really well, but being able to kind of recognize, but you did it. This was not easy and you did it. You had to force yourself and you mightn't have done it perfectly, but something happened there that you pushed yourself to do something hard because you recognized that you were worth it. And also strategies for some healthy self-reward so he can keep track of his progress and keep his motivation up. These are things that you'll notice are not new. I looked up on the online thesaurus synonyms for not new, and I like that. That's why I put it there. That one of the words it generated was unnew, and unnew I didn't know was a word, but now I think everyone should use it because I think it's an awesome word. These things are unnew to us. We're very familiar with them. It's not at all that different to what we'd be doing with somebody. Involves a lot of the same elements: skill building, tolerating sober living, self-reward. The main difference comes is that it's putting that trauma at the focus of it and locating it in the center of our shared formulation. While we're doing that though, don't forget that working with people's trauma can be very hard. It's tiring, it drains us. It can lead to burnout if we're not careful. And anyone who's experienced any of those symptoms of burnout knows that it's no way to live. It's horrible. It has effects on us outside of work with our families, and we don't want that. So looking after ourselves is important. We owe it to ourselves. It's a duty to ourselves and our clients to be seeking supervision, seeking support from our colleagues, and also to do the things that make us feel whole. So spending time with the people you love. That way we can be aware that there are horrible things in the world that happen to people. But there's also some really wonderful things as well that make it worthwhile. So attending to all of those things, that we need to do. Sometimes taking a day to be out in the garden or staring at the clouds or whatever is just as important as anything else we could be doing. And just in case that's brought up anything, here's a puppy, because that's always good to look at when when we need a bit of support. And that's the end. Hopefully there's some stuff in there, and hopefully I've left a little bit of time for questions. And hopefully there's some stuff in there that was useful. But yeah, I suppose if there's any questions that appeared in the chat box now, Chris will throw them at me.
Thanks so much, David, and a really good tour de force around trauma and those. As I wholeheartedly agree that a lot of the skills required, many people probably, you're right, I think underestimate themselves and their ability to manage it. As David was saying, please put your questions in the chat or raise your hand or whatever else. I appreciate it is 3:30, but I think it'd be nice if we've got a couple of minutes. If people need to go, then by all means. But if David doesn't mind hanging around for 5 minutes to answer a couple of questions, I think that'd be great.
Yep, I'm more than happy to. Or if no one has anything, I can leave you to your day as well. That's.
I was going to ask. Obviously, one issue sometimes for people is that you've seen a patient, you've spent 50 minutes with them, and then this sort of comes at the last moment, and you've got to, you do have other patients that you're about to see and trying to fit in other clinical demands. How do you not shut that down? That's not the right thing, but how do you sort of say, I am interested in this and I want to hear all about it, but also, still manage your calendar, so to speak, accordingly, and fit in the people, the other patients that you need to see that day and so forth.
And I think that's a really good point, because often that's when it does come up, isn't it?
So often, isn't
when
it?
you've got the least amount of time to do it.
Yeah.
And especially if it's a new one, I think acknowledging, like you say, that this is important, but also, and it might take time to discuss properly. I want to give this the time that it deserves. So to do that, can we agree to hold off on it now so that I don't start a half-assed conversation about it that just sort of makes it worse? And we can put this front and center of the agenda next time we meet. Most people I found seem to be okay with that if we frame it in terms of that this is not me putting it off, this is me putting off to a time when I can treat it with the seriousness it deserves.
Yep.
But it's hard because, part of us kind of goes, oh no, this is the stuff I've been trying to get them to say, and now they've said it and I don't have time to deal with it.
Yeah.
And it's yeah, I suppose it's still just a case of doing the best we can, isn't it, with the hour or whatever that we've got open to us. And sometimes it would be, wonderful to extend it, but also I think there's times when it wouldn't be wonderful to extend it. I can think of, if I was in like the third hour with one client of talking about their trauma without a break, because I'd let them go on with it. At that point, I wouldn't be doing them any good at all.
No.
I'm too exhausted to actually be a useful therapist. So.
And then I guess tied into that, sometimes there's a fear amongst clinicians that they open up this box and then the box is open and the patient's walking out of it, the room to, with an open box of trauma, and might go out there and take a bunch of pills, do something rash. In your experience, I mean, one, is that a justified fear? And secondly, if it is...
It absolutely can be, that can be, a result if we don't manage it well. It's not unfounded or irrational, but we can manage it, hopefully, so that we minimize the chances of that. We can never eradicate it entirely, but we can minimize the chances of it by hopefully, structuring the conversation so that it finishes at a point where the person's distress is lower, and checking in with them about what their plan is in the same way as we would any other risky behavior that's come out in the discussion during our assessment.
Yeah, and look, I think that's a really, really nice point. It's never wrong to ask a person, so what are your plans for the rest of the day, and where are you going from here? And
how are you going to look after yourself after this? This has been a big session. How are you, like, what's the plans? Acknowledging that you might even feel terrible after this, so have something already planned so that you can be at least feeling terrible while you're having a donut or something that might take your mind off it. And that in itself is also coaching and skill building around self-care that's going to be important down the track.
They're all very sage and I'm sure all of the clinicians here. Well, look, we've had our extra 5. I've dominated it. We haven't had any further questions.
Okay, cool.
But, that doesn't mean that I wasn't a thoroughly enjoyable...
I'll take that as meaning I didn't confuse anyone too much. I'll make sure I send through the slides if anyone wants them, and on that there'll be my email address anyway, so if anybody has any questions they can always flick them through to us after the fact. More than happy to be a part of that at all.
David, thank you so much for your time, and already getting some comments that no questions because it was a great presentation. So thanks very much, David.
Oh, thank you.
And
great.
We'll look forward to speaking with you another time.
Yeah, perhaps down the track. Cool. Have a good afternoon, everyone. Bye.
Thanks, David. Bye.